Hello, I'm Matthew Gavidia. Today on the MGH Life Sciences News Network, the Center for Biosimilars is pleased to welcome Kathy Oubre, Chief Operating Officer at the Pontchartrain Cancer Center in Louisiana. She is also the president of the Louisiana Medical Group Managers Association and a member of the board of directors of the Community Oncology Alliance. To get started, how much have you managed to incorporate biosimilars into practice at the Pontchartrain Cancer Clinic?
Hi there. We have actually done 100% conversion into any biosimilar for our formulary.
What kind of difference has this made in terms of budgetary efficiency for your practice, patient savings, and patient access?
It really hasn't changed patient access very much because those have always been approved by, the payers. It has changed patient out of pocket a lot when there's a cost sharing component between the payer and the patient. Um, Typically, we are seeing a savings of for patients up to about 20% of, and so it just really allows patients, they have a deductible. We all know that, but it's kind of like buying a car. So whether you can finance that car, you pay cash, or you finance it over 60 months or so. And as healthcare costs continue to grow for patients and they're struggling, especially during COVID, mortgages, food, clothing, those kinds of cost savings allow them to then, put money towards all of those buckets instead of having to pick one, which is in cancer therapy, that's a really big deal.
How are payer practices on prior authorization affecting access to biosimilars at your clinic?
It's become more complicated. So back in October, when the biosims for Neulasta came out, a couple of payers decided to go with one drug on their formulary, one pegfilgrastim, and perhaps it was not. It might have been the most cost effective for the plan, but maybe not the most cost effective for the patient, and that was interesting. We've seen that mindset continue to grow over the last several months, where lots of payers now are starting to pick and choose originators versus biosimilars. And a lot of that has to do with rebate design between, the PBM and the payer. And then there are, times where the manufacturers are having agreements with those payers as well. It presents a lot of problems, right? So we have to stock multiple products. That could be an issue from a nursing perspective. So, we've now had to put additional safeguards in place to make sure that nurse gives the patient the correct product. Because if we give the incorrect product or something that's not authorized by that payer, then the practice doesn't get paid for that. And then it takes a while to make up that loss. And there's not much we can do about that. It also ties our hands in being able to kind of just maximize our potential for any of these products, therefore lowering the cost for healthcare, for our practice in a value-based care model, and being able to provide the best financial value to the patient. And we're just seeing that payer, PBM, manufacturer, all those little buckets are continuing to grow, and they're making formulary decisions, and they're leaving the provider, the physician, out of that decision-making process.
How are rebate deals and other deals struck by payers with vendors or manufacturers affecting your ability to supply the biosimilars that you prefer to use?
They're tying our hands. It's just really that simple. So we prefer to use one certain pegfilgrastim. If we pick one and just move forward with it, from a design plan on pathways, it's very easy for us. From a nursing error perspective, it minimizes risk. When we do financial counseling, we have one drug that we've chosen, and from a financial and an efficacy standpoint, it marries well with our practice philosophy. But when different payers and PBMs and all those things make these outside agreements and we're just the end user, it does become problematic to operationalize it.
How many payers are you currently working with, and how much divergence is there in the biosimilars they want you to use?
We probably have 18 payers within our market. In the biosimilar space, we currently have 5 payers that really are picking horses in that market. And 2 of them within the last 30 days, each one of them picked a different biosim product that I now have to operationalize by July 1st. So then by July 1st, I will be using at least 3, and I'm hearing of a 4th biosimilar just for one drug that I'll have to, operationalize. You have to put different safeguards in place to make sure that you're giving the correct drug to the correct patient.
I know you touched on this briefly, but when it comes to factors such as stocking biosimilars, choosing the right biosimilar, and potential error rates and risk, how does flexibility complicate matters in your pharmacy?
It is complicated. So when the nurses are even ordering the drug, we have to make sure that where that correct drug is assigned to the correct patient, and that that correct drug was authorized for the correct patient. And then when it's time to administer it, then we have to make sure that the correct drug is being given to the right patient. And then and then billing it out. You have to make sure you're billing out the right drug for the right patient. So there's a lot of steps in place now to ensure correct buying, correct administration, correct authorization, and correct payments.
What should payers be doing to make the process more sensible for clinics and patients?
Parity, that would make things much easier. I understand the need for cost containment because we're all trying to do that. But when you take the physician and when you interfere with that physician-patient relationship, that's philosophically a problem. And when you don't allow parity, then you're not allowing market access, patient access. You're interfering with physician decision making. There's a lot of negatives for it. There's a lot of error rate. I'm not seeing a lot of positives coming out of that kind of decision making.
Can you tell us about the trickle down effect on biosimilar savings? How are these payer actions affecting your ability to pass savings along to the patient?
So just like payers have contracts, individual practices have contracts as well. So, and they're generally through my GPO, my group purchasing organization. So the contract might come to me, and if, when it's clinically appropriate, you utilize this percentage, then you get, and it could be off invoice discounts or rebates. And that savings goes directly down to the patient. So they don't have to pay as much for that product. When I have to stock multiple products, then it ties my hands in my ability to perform financially in an optimal manner on any of those contracts. So then, therefore, I'm paying more for the product. The payer is going to end up reimbursing me more for the product. And any cost share that goes, that's for that patient has to go to the patient, but it's generally on a more expensive product because I'm having to pay more for
To build on that, how is this affecting your providers and their ability to prescribe as they see fit?
it. What happens now in our practice is the provider picks the product, and then it's up to the financial counselors and those navigators to then go back and do a benefits analysis. And we have to marry what the drug is versus the insurance for that particular patient. Then that has to go back to the provider to say, patient A has this insurer and this is what they're requiring. Are you okay with that? So it also requires some extra steps, even within securing a drug for a patient.
To learn more, visit our website at centerforbiosimilars.com. I'm Matthew Gavidia. Thanks for joining us.